Thanks for joining us for this last roundtable of the day. In the interest of time, I want to begin just by having the faculty members introduce themselves quickly, your name, your title, and academic background or research interests or anything that you feel is going to help advance the conversation moving forward here. So, Veera, we'll start with you.
All right. So, I'm Veera Balandandayuthapani again, Chair and Professor of Biostatistics. I've been working in cancer research for 25, more than that actually. So my PhD was in cancer research doing spatial biology down south in Texas A&M. And then my first job before I moved here was at MD Anderson Cancer Center. So that's where I really got to learn a lot about cancer research, the whole spectrum of basic science to clinical research, and then I'm continuing here. Oh, the other hat I wear here that might be relevant to this conversation would be I also direct Cancer Data Science Shared Resource, which is a group of quantitative scientists, faculty and staff, both biostatistics and bioinformatics. And I co-direct that with Menggang, Dr. Yu right here. It was formed by Dr. Taylor here 20 years ago. So I have the honor to lead that as well. I'm happy to talk more about cancer research in general, but especially in Michigan as well. And Dr. Banerjee is a part of that Cancer Data Science group.
Hello everyone. You heard me talking a lot since this morning, but here I am again, Mousumi Banerjee. I am research professor in the department. Here I joined Michigan in 2003. My PhD was in statistics. I had nothing to do with cancer during my graduate studies. And I came into cancer research almost like by chance, by accident. So my first job as faculty was at the Wayne State University School of Medicine, where I joined to sort of be a part of a federally funded prostate cancer initiative. It was a university-wide initiative, and I landed up sort of being the card-carrying biostatistician there without knowing anything about sort of the science, cancer biology. So I kind of learned on the job. I started auditing cancer biology classes because the last time I had seen biology was in high school. So I started taking classes. I went to shadow my colleagues, and I sort of learned that way. And since then, I have loved being sort of in that with that research focus. So my work is primarily in the area of outcomes research, care delivery and outcomes research. So I work with population-based registries, EHR, linked registry data with administrative claims data, and to understand the variation in cancer care delivery and outcomes in the population. So a lot of population focus. I also, so I kind of built my career doing cancer work, but for the last 8-9 years, I also am director of a quality collaborative on pediatric cardiovascular, critical cardiovascular disease. The reason I bring it up is a lot of my cancer work, kind of from the substantive area focus, sort of there was a trickle-down effect in what I do as part of this pediatric collaborative. So, yeah, that's me.
Jeremy?
So I'm Jeremy Taylor, been here quite a few years, 28 I think now.
It was 27 back there.
Was it?
Hasn't been that long of a day.
Okay, you work it out. In 1998 was it, make it 27. So I was at UCLA before, professor there, and I was doing a lot of AIDS research there, and I just sort of came here to, part of a role was to sort of organize the cancer sort of research, statistics for cancer research at Michigan, and then, so that's based in the department here. So I've sort of moved around a lot in what I've worked on, sort of things related to clinical trials, some things related to sort of more methodological missing data, longitudinal data, and survival analysis, and cure models, and causal inference, and epidemiological studies, and surrogate endpoints, and just a whole spectrum of things over the years. And so from a sort of, I don't know, student perspective, maybe it's just getting ahead of where we might go, but from a student perspective, what does it mean to sort of be engaged in cancer research here? So we have a PhD program, training grant program for PhD students, and so that's, I used to direct that, I co-direct it with Veera and Kelly Kidwell now, and so that has people whose funding will come from this sort of fund that's dedicated to making sure they learn something about cancer. So that's sort of one perspective from the students. Then there's quite a number of students who are GSRAs, so research assistants with Veera, or with Mousumi, or with Matt Skipper, or with sort of faculty here who are involved in sort of project type work, which will have some cancer focus, and it might be in sort of outcomes research, or Veera, it's going to be more sort of molecular, or sort of a whole range of things. And then we also have some classes. I mean, most notably in the fall, we've organized a seminar, sort of Cancer Biostatistics seminar. So it's open to anyone, until we get speakers, some internal speakers, and all these folks have spoken. And then we get about 4 or 5 external each year, and so some visitors come in, statisticians, famous or not so famous, who involved in cancer research, and they come and tell us what they're, what they work on. So students can sort of just see what they work on. Sometimes there's a very technical talk, sometimes they're very applied talks, but there's sort of an easy way to sort of just get a feel for what statisticians do in cancer research.
Thank you, Jim. Menggang.
Okay. So I'm fairly new here. I joined the department last year as a professor, but I started cancer research in 1999, a year after Jeremy joined, and I became his student at that time. So my thesis at that time was in prostate cancer, individualized prediction of cancer recurrence based on PSA. So that kind of jump-started my career. And then I took my first job at Indiana University. I worked a lot with cancer, and then about 12 years ago, I went to University of Wisconsin-Madison, and I was the Biostat Shared Resource Director there for 12 years, and so then joined here. So just like Veera, being the director for the Biostat Shared Resource, I had to work with all kind of cancer-related projects, provide advice. So, not only just therapeutics, but cancer prevention, behavioral studies, and all these kind of things, and biomarker studies. So do a lot of these. So as I said, here I'm relatively new, but I do for cancer. If I have to pick some research areas, I do personalized treatment recommendation, causal inference, and basically all methodology related to clinical biostatistics for cancer research.
Excellent, thank you. So with all that said, I want to start with breaking down, we've done this in all of our panels so far, I want to break down the word biostatistics into the bio part of it and then the statistics part of it. So I want to start with the latter part first, and talk about the various statistical methods or methodological areas. How do you adapt, how do you create these methodologies to help you answer these research questions that you've been discussing? What are some examples of ways that you use your methods?
Use your methods?
Use, create, develop, however you want to address that.
So cancer is a broad area, right? It's a big disease, and a lot of the cancers are different, and the sort of data that comes out of cancer studies is a whole spectrum from very laboratory basic science to populations and people and treatments, and so there's a whole spectrum of statistical methods sort of motivated or linked to those data, and so some of the very common ones which you'll learn in core classes here, survival analysis and longitudinal data, they're very naturally used in cancer type studies.
Yeah,
There are-
yeah, categorical data is another one. And I sometimes tell students who come, to see me about advice regarding course choice. I have said to students that, if you are graduating out of a biostat department and you are doing work in cancer research, it's a crime not to take a course in survival analysis or categorical data. These are some methodologies that are widely used, like kind of fundamental classes. And then in terms of, as Jeremy said, there's a wide spectrum. I mean, my work is focused on populations, so sort of having the expertise, knowledge to work with big data, observational data, sort of the nuances that come with observational data. All of these become important again, it's a wide spectrum. And I'm sure Veera can comment on kind of personalized cancer care. Like
on the molecular end of
on
things.
the molecular end of
and Menggang works on the clinical side of things. Yeah. So I guess, I totally agree with what Jeremy and Mousumi said about, the flavors of data that come out. A lot depends on the scale of the study. But a lot of data that's collected, especially from technologies, have a lot of structure in them. So the structure is like longitudinal is one, that's time series. But there could be other kind of complicated structures. For example, now, new kind of data that's being collected now is spatial data, which comes from imaging and other aspects. So part of it is like how to analyze that, and sometimes it always almost happens that there is something off the shelf that can be used to analyze that. But there is also room for creativity where you can develop methods if something is not out there, and that's what essentially feeds into research projects and dissertations and those sort of things. So that's sort of, that's what has, I guess I can speak for myself, that worked for me, is thinking about, working with a collaborator, and especially it's nice working with a local collaborator. We have a very, very strong cancer center here. It's called the Robo Cancer Center, one of the top ranked in the nation. With a very, very good deep research happening across all fronts, basic science, population, clinical, translational. So working with those investigators, and when you collect that data, like they are invested in it, so they want to extract maximal information, and that's sort of our job, how to get that.
So Veera's works a lot with spatial genomics data, where they're doing sort of very fancy imaging and they're measuring genes and expressions and things like that at the same time. So one of the methodologies are sort of borrowed and adaptive from sort of geographical statistics or spatial statistics or mapping. And so, so that's the basic technique, but then you have to adapt it to sort of the setting and the science and the motivation and the goals.
Yeah.
So there's a lot of, regular statistics, but gets sort of tuned or adapted, and you really sort of have to get to understand the scientific context and the data structure to do that well.
Menggang, do you have anything to add?
Yeah, if I may add, we also work a lot with design aspect of projects, how to design a study, make it more efficient, make it feasible. So, for example, recently I worked with a project where it's a randomized phase 2 study, so you want to conduct the study in a most efficient fashion, so we actually have to do an interim analysis for futility stopping, so that if the drug compound is not useful, you stop it, right? But at the interim analysis, what kind of outcome do you use? Because if you use the final outcome, it's not ready for you to collect all the outcomes. So I guess my point is that you have to, when you think about helping the investigators to do their studies, you also think in a more practical fashion, what's feasible, how to make most out of, the situation, and, from a statistical point of view. So we also work with that.
Excellent.
I'll just add one comment to Jeremy's point about sort of understanding, recognizing the data structure. So in a lot of studies that I work on, because I'm interested in understanding the variation in cancer care delivery, And typically what you have is you have data at the patient level, but patients are kind of nested within providers. Providers are nested within hospital systems. Hospital systems are nested within like regions. And there is variation at each level. There are covariates at each level. And you are trying to understand like what is it that impacts the outcome like at these different levels. Is it about the provider you go to? Is it about the hospital you go to? Like what is contributing to the disparity in outcomes? So yeah, the structure of the data becomes very important.
Excellent. Thank you. And then, moving on to the application part of it, I think all of the methods that you talk about here allow us to do, or allow you all, I'm not a biostatistician, allow you all to do exciting breakthrough research and apply that in ways that are innovative, groundbreaking, impactful. Can you talk about some of the current applications that you're doing for your research? And then, looking forward, we talked about some data that's, new sources of data that we've been talking about, electronic health records, imaging, all these sorts of things. Can you talk about how those data are unlocking new frontiers in cancer biostatistics and new exciting applications in the near future?
So go ahead.
No. I think Jeremy already hit on this, and I can talk on and on about this, but I'll keep it short. I think one of the things is spatial imaging that's come about, and spatial genomics that's come about. And for those of you who are already here for the previous panel, Dylan might have talked about it, and Dylan and I are working on a project together too. And that's come about over the last 5-6 years. It's funny because my dissertation was on spatial biology, but that was manually collected data by a postdoc in a lab, counting the cells and mapping them and measuring distances under a microscope. But now technology can do that. So what really got me excited about this is just so it was sort of mapping, at a high level it's mapping all the tumor geography, so to speak, and then and how does that, and this is data that can be collected on patients, but what excites me actually about this is I'm working with a clinician right now, a surgeon actually, who wants to develop an imaging biomarker for this and how to deploy it in the clinic, because this is pathology samples, and as you know, any cancer patients, that's the first level of diagnosis, that is do a biopsy and get a pathology. So can this be assayed at a biomarker level and used for treatment response or prognosis or do something? Gabby, you're in BDSI, you know all about this, no? So that's at least one, that's sort of caught my fancy over the last couple of years now. That's where, and this data needs statistical models. It's spatial in nature, like the clinicians can only see the pictures and they can make visual, I can see this, but how do you quantify that? And that's where all the statistics comes in, and when you need to make uncertainty quantification, that's vitally important. And I'm on Zoom, but I'll say AI won't solve this, basically. The clinicians need an interpretable model that they can base treatment.
So you said AI will solve it, or
will not
solve it?
solve
Will not. Okay.
Will not solve it.
That's good.
Will not.
Will not solve it. Underline not.
Any other exciting applications that you all are looking forward to in the very near future based on?
So Menggang on his dissertation worked in this prostate cancer setting and sort of modeling longitudinal variable blood draw as a number, and sort of how does that relate to sort of clinical development of a disease where a person has symptoms of prostate cancer. So we're still doing that, and so what we've done at the moment is something called dynamic treatment regimes, where you get to sort of decide on a treatment for a person, but it's sort of dynamically decided. It's not like a clinical trial, just give drug A up front. So this is, you follow a lab value over time in a person. If it starts to look bad, you make a decision to stop the therapy. And so that sort of got into questions of causal inference, which is sort of a topic which is quite popular in biostatistics, epidemiology, and econometrics. too. And that's an area where there's actually sort of quite a contentious field in statistics. There's very opinionated people in the causal inference world who are very adamant that you do it my way or you're not doing it right. And so, and we weren't doing it sort of the way these adamant people were doing it, so we had to get into trying to justify sort of mathematically the assumptions we need to make sure our method was valid. And so that's actually what excites me. I'm happy to be involved in cancer research, and it's important, but I'm actually more excited about sort of when I could see the statistical and the mathematical stuff sort of tying in and being relevant and making me feel good that I'm sort of doing something well and doing it right. So.
I can say to that. we when I was doing thesis that was 20 years ago, a lot of discussion about statistics, how the assumptions underneath the model development and stuff like that.
Yeah, I can talk about something that I'm very excited currently that working on with colleagues in endocrine cancer, where we are leveraging both cancer registry data but also institution-specific clinical registries and survey data to understand hidden disparities in care. What do I mean by hidden disparities? So we have studied extensively racial ethnic disparities, but what about language barriers? So again, tying in ideas from data integration, causal inference, but ultimately, it's almost I feel very humbled that we are able to contribute to understanding these kind of hidden disparities. If you are not a native English speaker, are you getting the right access? Are you even reaching the right group of providers, the right clinic? And that's something that I'm quite excited about. We, in fact, recently, our team was awarded the Endocrine Care Innovation Award for outstanding research in the last 5 years on care delivery in cancer.
Well, thank you all so much for your contributions to this panel today. I believe you're going to be hanging around for just a couple more minutes before the 2 o'clock lunch hour ends, so if you have any questions of the faculty members here, please feel free to catch them in the assembly hall. We're going to reconvene in this room in about 10 minutes for an alumni panel, but in the meantime, please enjoy the last little bit of lunch and make some connections, and thank you so much.
Questions?
We're going to do questions over in the assembly hall.
Oh, okay.
Yeah, in the interest of time. Yep. So if you have questions, feel free to catch them in the